Are we happy? Is everyone there?
Yeah. Okay, so ladies and gentlemen, today we have Dr. Hassan Malik from Liverpool, who will be giving us a talk about the consensus on management of synchronous colorectal liver metastasis. Thank you, Dr. Hassan, for joining us, and the floor is yours.
Thank you very much again. Nice to see you all again. So I just wanted to provide a very brief update on this, which I think is quite important, and then we can have a broader discussion once we stop talking. So this is the multi-society European consensus on the terminology, diagnosis, management of patients with synchronous colorectal liver metastases. Now, this was an initiative by the EAHPBA, and it's also supported by ESSO, which is the European Society of Surgical Oncology, and also by the European Society of Coloproctology, as well as the various radiology societies. Now, the management of colorectal liver metastases is something we as liver surgeons have been talking about for a long time. This was a previous consensus in the treatment of this disease, which was had a number of key people involved, including obviously Rennie Adam, but my previous senior colleague Graham Poston was involved with this as well. And this set the standard in terms of management of this disease. And what we know from historical data, and this is data from LiverMet survey, the people are diagnosed with disease in a synchronous fashion, i.e. the primary is diagnosed with metastatic disease. They will do worse than patients who are diagnosed with their metastatic disease at least a year after the colorectal cancer is diagnosed. So that synchronous presentation does seem to have an impact on patient prognosis. But this is just a univariate analysis of one factor. There clearly are other factors that do predict outcome of patients. So why talking about this again? So this was an initiative led really by Ajit Suradina, who was the then president of the European and African HPB Association. He talked to myself as secretary of the European Society of Surgical Oncology, brought in other stakeholders, including the European Society of Coloproctology, the European Society of Gastrointestinal and Abdominal Radiology, as well as the Interventional Radiology Society. Now, the one group who is clearly missing from this is ESMO, the European Society of Medical Oncology. Now, they were invited to take part, but due to a number of factors, ultimately did not formally take part in this process. But where we did agree is that we would reference any ESMO guidance that was relevant with regards to medical oncology treatments, but also medical oncologists were involved in this process from the beginning. So the first step happened in January of 2022, where we developed a group of people, experts, to develop the consensus. This led to a number of questions that were defined. Following this, there was a meeting in the EAHPBA in New York, which led to the first round of the Delphi process. I'm assuming you all know what the Delphi process is. And this is a way of basically collating answers and best answers from a number of experts. So the first round happened towards the end of 2022. Any responses with less than 70% concordance between the recipients were removed. This led to a number of statements which were assembled. Then responses to those statements from round one, which had less than 70% agreement, were removed. This led to a second round of the Delphi consensus, which happened towards the end of 2022. And this then led to further statements being again removed, which there was less lack of agreement. And then we had a final series of statements and discussions in Zaragoza at the end of 2022. So this is a beautiful picture of Zaragoza, and we met in the medical university buildings there. So now what I'm going to go through is the specific agreed statements and terminology, and then we can maybe have a bit of a debate and discussion about whether this would fit with your own personal practice. I have highlighted a number of areas where perhaps this consensus would disagree with current practice in our own unit in Liverpool, for example. So the first aspect is to do with terminology. So liver metastases detected at the time of diagnosis of the primary are termed synchronous. The definition of synchronous liver metastases also includes patients in whom incidental liver metastatic disease was detected intraoperatively, for example, in an emergency setting. To be termed metachronous, the metastatic disease should have been excluded on cross-sectional imaging at the time of diagnosis of primary tumor. And ideally, liver metastases need to be detected 12 months after the diagnosis of primary tumor, but absent at presentation. If the metastases are diagnosed before 12 months, then they can be termed as early metachronous tumors. So that's basically there. So if they're diagnosed after 12 months, they're diagnosed as late metachronous tumors. Now, this business about detecting tumors up to 12 months after the diagnosis of the primary tumor being termed early metachronous tumors. So you may understand, and I've talked to you in the past about the management of oligometastatic disease, and in particular the management of non-colorectal, non-neuroendocrine oligometastatic disease. And in all the definitions of metachronous oligometastatic disease, the cutoff is 6 months, not 12 months. And why this is important is that certain treatment modalities, for example, ablative radiotherapy, are commissioned, certainly in the UK, they're commissioned for oligometastatic disease, including for colorectal cancer. But for this to be commissioned, it needs to be up to 6 months after the primary tumor. So there is a bit of a kind of conflict here in terms of definition. Right. The other aspect is around the tumor board. So the consensus also recommends that all patients with liver metastatic disease from colorectal cancer should have their case reviewed at the multidisciplinary team meeting or the tumor board with an expertise, and this is crucial in management of liver metastatic disease. And in practice, the composition of this tumor board is a compromise between an ideal situation and the reality, which varies from institution to institution. So one has to be pragmatic. But broadly, in terms of diagnostic tests, these will follow ESMO guidance. We would recommend the liver MRI with hepatobiliary contrast agents is undertaken before chemotherapy is prescribed. Histological confirmation of the primary is adequate to diagnose liver metastatic disease. We do not recommend biopsying liver metastases. Measurement of CEA baseline for surveillance, that's, I think, pretty standard. If feasible, determine mutational status with RAS, RAF, and HER2 amplifications. Obviously, in some Western healthcare systems, that would be all RAS and also MSI high tumors, again, looking for the role of immunotherapy. Now, it does state that routine use of FDG PET is not recommended. Now, that I think is a bit controversial. Certainly in our institution, we would use PET scanning in all patients. Now, what about the urgent presentation? So the consensus recommends the surgery aimed at addressing the emergency complications of the primary tumor should be considered after appropriate resuscitation of the patient. But we do not recommend that intervention to the liver metastases should be undertaken during the emergency presentation. We also recommend that stenting can be used or defunctioning stoma or resectional surgery in patients with intestinal obstruction where there's appropriate expertise. Now, in terms of upfront synchronous resection, so in terms of this consensus, upfront synchronous resection applies to patients in which a single operation can deal with the primary and the metastatic site, okay, and under one general anesthetic. Now, we do acknowledge that for all extents and purposes, the management of colonic and primary tumor will be different because of the role of radiotherapy in rectal cancer, for example. also acknowledge that there's a different biological behavior in terms of left and right-sided tumors, and this all needs to be taken into account in terms of how we manage these patients. But there are a number of recommendations that are made. So although we do accept the synchronous resection of the liver and colonic tumor can be done technically, but the vast majority of patients will receive systemic chemotherapy as their initial treatment, not surgery, unless, for example, the patient is elderly, has a low burden of disease, and is not deemed suitable for chemotherapy, in which case you may go to resection as a primary modality. But the vast majority, you would be starting with systemic chemotherapy. Now, the consensus does not define the feature remnant liver volume, but it's important to note that, for liver surgery, you need to have adequate liver volume, biliary drainage, portal and arterial inflow, and hepatic venous outflow. There is a separate consensus statement that EAHPBA and ESSO undertook based around a meeting in Innsbruck, and the outcome of that consensus, which is all around treatment of patients and assessing feature liver volume, and this was published in the BGS. So certainly, if you want to read more about that, then the article in the BGS is something I would signpost you to. Now, we also recommend that where upfront synchronous resection is to be undertaken with a colectomy, the liver resection should be a minor hepatectomy. And again, this statement, I think, is probably somewhat controversial. Certainly in our institution, we would be happy to undertake a standard hemihepatectomy with, for example, a right hemicolectomy, but we would not plan an extended hepatectomy with a rectal resection, for example. But there will be units with experience that may take on a major hepatectomy with a colonic resection. Now, in terms of consideration for upfront systemic chemotherapy, this needs to take into account performance status of the patient, comorbidities, presence of extrahepatic disease, peritoneal disease included, and in scenarios of rectal cancer where radiotherapy might be used. Now, there are a number of strategies that we have. So the first is the traditional bowel first approach. And this is where the patient has the primary resected, perhaps in an emergency setting due to imminent obstruction or perforation. And then the liver aspect of that would be following chemotherapy. And obviously, we would recommend that these patients are restaged and further MDT discussion between the surgical stages. Resection of an asymptomatic colorectal primary is not recommended in the presence of non-resectable liver metastatic disease. Now, that's an important statement. It's based on level 1 evidence. However, again, there's an issue of controversy. I don't know what the state of play in Egypt is, but in the UK, there is a new program which has been opened on liver transplantation for patients for liver-limited, irresectable liver metastatic disease. But crucially, in those patients, the primary tumor, which may be asymptomatic, has to be resected before the patient is considered for transplantation. So this is a potential issue in the UK. And those patients have to be, in the UK, according to the guidelines, have to be stable for 2 years of chemotherapy. So we have a problem where we have a stable patient on chemotherapy with liver-limited inoperable disease with an asymptomatic primary in situ. And when do you think about resecting the primary if you're considering a transplantation? So that's an issue. Now, what about the liver-first approach? So this can be applied where the burden of liver disease, especially if it's borderline resectable, favors the hepatectomy first after the systemic chemotherapy. Patients, and also in patients with rectal cancer who have had chemoradiotherapy, where there is need for a prolonged period of response, then the liver resection can be undertaken in the window between the completion of the radiotherapy and plan to resect the primary tumor. But obviously, you may have a situation where patients with rectal cancer and liver metastases who have a complete response of the primary tumor to neoadjuvant therapy And we know from data around total neoadjuvant therapy that up to 50% may have a complete sustained response. Then the liver first may become the liver only approach, i.e. you deal with the metastatic disease in the liver, and the primary is being basically destroyed by the systemic treatment and radiotherapy. So in summary, this is a major multidisciplinary exercise which has reviewed the current management. We do provide precise definitions of synchronous and metastatic disease, as well as guidance on patient selection. The other point to mention that the recommendations of this consensus are contemporary, and they provide practical information to clinicians who manage synchronous colorectal liver metastases. And so this consensus has led to a number of publications. This was the publication in the BGS, and then this was a follow-on publication in HPB. In terms of future work, Thomas Grunberger from Austria and my colleague Rob Jones are working on a research gaps analysis, and will be providing future recommendations with regards to research in this area. I think that's all I need to say. Thank you. So I need to, can I stop sharing, or how do I stop sharing? Stop sharing. Good. Everyone's quiet. Hashem, are you muted or are you frozen? Hello? Is Hashem left the call? Is he? Should we take questions? I don't know if Hashem's. Can anyone hear me? Can you hear me?
Yeah, I got disconnected.
Oh, God, I was wondering. Everyone was quiet.
Yeah, there was something wrong with the connection. I got disconnected. So yeah, let's start by taking questions. Please, if you have a question, raise your hand. Let's start with Dr. Muhammad Adel.
Precise.
We cannot hear you.
I have a. Can you hear
Hello?
me now? Hello?
Yes, go ahead.
Hello? Thank you, Doctor.
No.
I have a question. Is there a consensus regarding... Hello?
Yes, hello.
Can you hear me?
Yes.
Try, say your question.
My question is there a consensus about management of multiple bilobar liver metastasis?
So this consensus didn't cover issues around technical resectability and things like that. I don't think there is a kind of a specific consensus on that. I mean, ultimately, I have a whole new talk on the management of bilobar liver metastases, but ultimately it comes down to surgical decision about operability, whether you do two-stage hepatectomy, ALPS, one stage where you combine resection with ablation. So that's really a decision that the surgeon and the MDT can make about technical operability. Then there's the aspect of oncological sense and patient prognosis, and undertaking such complex surgeries and what benefit it causes the patient in terms of long-term survival. The best biomarker we have, to be honest, is response to chemotherapy. So patients like that will often get systemic chemotherapy, and if they have a good response, then we would give them an option of surgery. And then there's the patient fitness that has to be taken into account. With our imaging, with MRI, diffusion-weighted MRI, we will see things which are 1 or 2 millimeters across. So you may see 4 or 5 big things, and then you see 100 little things in the liver, and then you really have to think about whether surgery is the right thing. But that's the type of scenario where liver transplantation may offer some scope, in that type of situation where you don't think you can remove everything with liver-limited disease.
Okay.
Yeah, you got it. You got that answer. Yeah.
Dr. Medhat Khafaga.
Thank you, Dr. Hassan. I have a few questions. First question: if you do staged resection, what is the period between the first, for example, bowel first, and then the resection of liver metastasis? That's one question. Second question: if you give chemotherapy and there is complete PCR to the liver metastasis, will you open this patient or you wait until it grow again? And for example, if you open one of these patients for a complete PCR and with intraoperative ultrasonogram, you couldn't locate the tube, what you will do?
Yeah. So what I would say is that the traditional bowel first approach, in our experience, is getting less and less, because one of the problems which used to happen traditionally is a patient presents to the colorectal team, they have a bowel cancer, they resect that, they may partially stage the metastatic disease, they may not do an MRI or a PET scan, they may get poor quality CT, they don't necessarily see the whole burden of disease, they have the bowel operation, they may have a complication, then months go past, the disease in the liver progresses, and then so you go from an operable curative to a palliative situation. So the message from us is to get all the patients into the tumor board for that discussion. Apart from rectal cancer, I think most other cases we would try and do a simultaneous resection. For left-sided tumors, we'll probably do a stoma. For right-sided tumors, primary resection and anastomosis. We can combine resection of the primary tumor as part of the first in a two-stage approach. So often in a two-stage approach, you would do a minor hepatectomy on, say, on the left, and then ligate the right portal vein. But you can do a sigmoid resection as part of the first stage, for example. So ideally, the message is get the patients into the tumor board, have that discussion. Most patients will probably assume their fit will be suitable for a synchronous resection, apart from rectal cancer, where you're going to irradiate the rectum and then wait and do the liver first approach. Generally, in terms of delay between treatment and liver surgery, the main delay is after chemotherapy. So if they've had systemic chemotherapy, we'd want to wait 6 weeks for them to fully recover before we operate. So, in terms of bowel, if they've had a bowel operation, and when is it safe to have the liver? Well, whenever they've recovered from the bowel operation, so that may be a few weeks or whatever. But to put patients through 2 general anesthetics in quick succession isn't great. The other question was around complete response to chemotherapy. So in the old days, we would always assume that about 84% of these patients who've had a response to chemotherapy on CT will have relapse. So there's always going to be disease. So it's certainly worth going in and doing a laparotomy or doing. That's what we thought based on data from the 80s. We published our own series in the EGSO. All our patients have had a PET. All our patients have had a diffusion-weighted MRI scan. And if you look at the lesions that have disappeared on chemotherapy, per lesion on a per lesion basis. If it's not visible on an MRI, on follow-up, less than a third of these patients will get disease at that site. So, like we do a watch and wait in rectal cancer after radiotherapy, I think there is something to be said about doing a watch and wait in liver metastatic disease after response to chemotherapy, assuming you're doing proper staging with MR. What I would do in that situation, if there's a complete response, I wouldn't take him to theatre. I would do an interval MR at 3 months. And if it comes back, it'll usually be low volume and we can ablate it. That's assuming every lesion that was present pre-chemotherapy has disappeared. That doesn't happen very often. So what you'll see is a mixed response. You will see some lesions that are there and some have disappeared. Those patients you're going to take to theatre, and then you have a good look and do an intraoperative ultrasound and treat what you can see.
Thank you. There is another question. Can I ask another question, Dr. Hisham?
Yes, sure.
When I asked Dr. Thomas Starzel about liver transplant in these patients, he refused utterly in the conference and I was attending. And they were afraid at that time from immunosuppressive therapy. Did you, those guys who are doing the liver transplants, there is any evidence that immunosuppression for liver transplant will make tumors recur?
Yeah, so the data that's pushed the transplantation agenda is the Scandinavian studies, I think is, I can't remember the name, but there's basically 2 trials, or not really trials, but they're basically prospective registry type things. And essentially what they found that in patients with inoperable disease, based on liver burden of disease, the 5-year survival was about 70–80%. So these patients were alive, but they were alive with pulmonary metastases. Okay, so I don't think that I completely accept the concern about immunosuppressants and cancer biology. So, but what we see in these small series from Scandinavia, that these patients are going to be alive with metastatic disease in the lungs, but no disease in the liver. Now, in the UK program, they have stipulated that the patient has to be stable on systemic chemotherapy for 2 years before consideration for transplantation, and the primary has to be resected. Now, it comes to the point I've made already that how many times would we recommend resection of a primary tumour in the palliative setting? We don't, in an asymptomatic primary, but this is the problem with the transplant question. And I rarely see anyone who is stable on chemotherapy for 2 years. So the criteria in the UK are so tight that I don't think many people will be transplanted, to be honest. But it is a valid point. But I think as a SECA 1 or SECA 2, I think there was 2 Scandinavian studies that were small studies which set the scene for transplantation for metastatic colorectal cancer.
How many patients were transplanted in this situation all over the world? How many patients were transplanted in the different centers all over the world?
Yeah, I don't know about the different all over the world. Let me just check my previous presentation because I have the data. The data that I have is for the 2 Scandinavian studies.
How many patients?
I'll tell you in 2 seconds. I'll just tell you it right now. Let me just find the right talk, and then let me see if this is the one. But we can carry on taking questions while I find that right number for you.
If you remember the number, is it in the tens or the hundreds or something?
No, it's tens. It's not hundreds. Definitely not hundreds. Let me let me just get that from my older talk. Just 2 seconds. But I can carry on taking questions while I get this other PowerPoint open.
That's okay. We'll wait.
Okay.
Oh, yeah. Let me just see. I'll try and screen share as well if I can find the right bit. My computer is playing up at the minute, so just bear with me. Yeah.
Doctor, we have someone saying Oslo study about 40 patients.
Yeah, there's pretty much that. I think there was 2 studies. The thing is, in Scandinavia, they have more organs to transplant than they have recipients. Whereas in the UK, there are plenty of people dying waiting for a liver transplant with benign disease. So,
Okay, take another question, Dr. Ajazwani.
Yeah, so SECA2 had 5-year survival of 83%, published in Annals of Surgery in 2020. 21 patients in SECA1, and that had 60% 5-year survival. I think SECA2 might have had a bit more, as you say, 40-odd patients. But the first author was Svein, S-V-E-I-N, so you can check that on Annals of Surgery in terms of there. But there was these 2 Scandinavian studies.
Thank you.
Okay, Dr. Ajazwani.
Yeah, good evening, everyone. My question has few parts. Since with the synchronous liver mets, we usually go for upfront systemic chemotherapy module. My question was, what chemotherapy modules? As we understand it, we usually start with them on either FOLFOX or FOLFIRI. Then we go up the first line of biologicals. Then we go on the second line of biologicals. So how far do we test their biology or test their response? And wait for the primary to get symptomatic? Do we have a window period here? Do we wait for some time?
Mm-hmm. So I would always defer the chemotherapy discussion to the oncologist. Generally in the UK, they would get a doublet with oxaliplatin as the main chemotherapy. So FOLFOX would be a standard chemotherapy. Most of our oncologists tend to go with that first before FOLFIRI. In terms of cetuximab, biologic, there is a controversial issue around the results of the new EPOC study, which was a trial which showed potential harm, maybe, with cetuximab in addition to FOLFOX. So that's the way the authors of that trial have phrased this. So our oncologists will not in the UK be willing to provide cetuximab in the perioperative setting, for example. But if we say that the patient is currently inoperable, then yes, they will give cetuximab in RAS wild type. In the UK, again, we don't have access to bevacizumab unless the patient is privately funded. But in the States or in Europe, I guess, bev may be added in the mutant arm of patients. But that generally is the oncology decision. They would generally get about 3 months of chemotherapy, at which point we will reassess. In terms of symptomatic primary, essentially, if the patient is symptomatic, they need something done. So they present with symptoms at the beginning or during the chemotherapy, then that needs addressed. So that might be a stoma, it may be a stent, or it may really be a resection. But be aware that systemic chemotherapy will also treat the primary tumor, and we do see responses in the primary to the systemic chemotherapy as well. So the patients may start off with some symptoms, and then when they get chemotherapy, the symptoms may resolve because the tumor is being treated with chemotherapy.
Thank you.
Thanks.
Dr. Asma.
Hello?
Hello.
Yes.
Can you hear me?
Yep.
Yes.
Okay. For the cases that liver metastasis that is operable and also has peritoneal metastasis, when you can do peritoneal resection for this patient?
So again, this is something that in the UK is the approach may be different than in Europe or perhaps in Egypt. In the UK, peritoneal surface malignancies based in basically 3 hospitals in England: the Christie Hospital, Basingstoke Hospital, and one of the hospitals in Birmingham. They are very selective in who they take on. Generally, if patients with peritoneal disease have visceral metastases, whether it be liver or lung, traditionally they have been reluctant in taking those cases on, I have to say. I get the feeling that it's changing a bit. And if we as a tumour board say, look, the liver metastatic disease is small volume, is treatable by resection, ablation, whatever, then I get the feeling that they may be willing to take these patients on. But traditionally, they've been very conservative compared to what I see happening in Europe or elsewhere in the world.
Okay, thank you.
Okay, Dr. Wael.
Yes, when I changed my plan from surgical to non-surgical management of metastasis in the liver.
So the first thing to say, when we were in Zaragoza, the preliminary results from the Dutch trial, which was collision, was presented there. And this is a trial where they compared head-to-head percutaneous ablation to resection for sub-3 centimeter tumours. And in terms of oncological outcomes, both resection and percutaneous ablation were equivalent. In terms of perioperative outcomes, ablation was superior because it can often be done as a day case, and the morbidity was minimal, unlike surgery, which has more risk. So I think if you have patients with low volume disease in terms of small size of tumour, then yes, you could ablate those. And increasingly in our tumour board, patients are going down the route of percutaneous ablation versus resection. In the collision trial, which is yet to be published, I believe, the number of lesions treated were up to 3, I think. But our IR people will be happy to ablate more lesions in maybe 1 or 2 settings. So I think ablation is a viable option to resection. But you have a situation where you may find that the burden of disease in the liver is too great to resect. But then you have the transplant discussion. But then there are other options. So the other options would be radioembolization, for example, SIRT can be used. The big trials of SIRT were negative, but in the UK, it's licensed in second-line treatment. Chemoembolization, so we use TACE for HCC, but a variation of TACE with Debiri, so it's beads with irinotecan, can be used, and that has some people who like it around the world. So there are a number of other options. Radiotherapy, ablative radiotherapy, SABR, maybe an option for a solitary lesion, for example, which is deemed too big to resect. So there's a number of options that people can consider. They all have to be taken into account with the tumour board and the patient wishes and fitness and things like that.
Okay, Dr. Walid.
Yes, hello, Dr. Hassan. It's always a pleasure to have you among us. I have 2 questions, please. The first one, how do you define an adequate future liver remnant according to this new consensus in terms of number? This is the first one. And the second one, how do you manage those patients with colorectal liver metastasis and isolated lung metastasis?
Yeah. So in terms of future remnant liver volume, this consensus didn't specifically deal with that. There is a separate consensus that we did in Innsbruck. That's again published in the BGS, so please look at that. Stefan Statner, I think, was the first author or lead author of that. He was one of my previous trainees. I mean, generally, you know, we want in a non-cirrhotic 30% at least liver volume. Cirrhotic 40%, that's the ballpark. but that's based on volume. It doesn't look at function of the liver. Patients who are heavily treated with chemotherapy, their liver function may not be good, so you talk about ICG clearance and things like that. But the consensus is published in the BGS, and so just go and read that. It's a really good document, and it lays out all the data to now, and gives a very nice algorithm of how to manage the feature remnant liver volume and what to do in terms of hypertrophy. We talk about ALPS. We've never done an ALPS in Liverpool. We feel the morbidity from ALPS is perhaps too high. The thing that may change everything is dual vein embolization. There's a DRAGON study, which is led out of Maastricht, which is showing some really interesting results in terms of dual vein. So that's portal vein and hepatic vein embolization. And that seems to give very good liver hypertrophy. And so that might be actually a very good position, which is better than traditional two-stage with portal vein embolization, but less risky than ALPS. So, but all that's in the consensus. In terms of lung metastasis, yes, we take out lung mets. We personally don't. Our cardiothoracic colleagues attend our tumor board, and they will happily resect lung metastases after the resection of the liver and the primary tumor. Occasionally, if the lung met is in the lower lobe, we get the thoracic guys to come to our hospital, and they may just go through the diaphragm and resect it at the same time, but that's rare. Again, if we're doing ablations, our IR team can ablate lung mets. So low volume lung metastases is not a contraindication to resection.
Okay, thanks a lot.
Good evening, sir. Thank you for this beautiful presentation. I want to ask you about in cases with the liver mets and higher pathological nodes, either by PAT. Do you consider these patients should be treated with the aim for cure, or are they deemed metastatic?
I agree. Again, comes down to biology. If there's regional nodes, they can be resected at the same time as a hepatectomy. We don't routinely recommend a lymphadenectomy in these patients, but we do PET scan, and it will identify some regional nodes. I think if the nodes around the para-aortic area are celiac, then that would be advanced disease. But what we would recommend, if they're identified, we would give them systemic chemotherapy, assuming there's response and stability, at the very least stability, ideally response. Then we will resect the regional periportal node with the hepatectomy. But biologically, they may well do worse. But no, it's within the field of resection. We'd be happy to resect that.
Okay, is there any prognostic impact for such nodes?
Yeah. I mean, if you got extrahepatic disease, they do worse. Yeah. So, but it's resectable extrahepatic disease. There is another. The Dutch are amazing. There's another Dutch trial which is looking at the role of debulking surgery. So the premise behind that study was to say that if you can resect 80% of the volume of the disease, okay, so it's palliative surgery, but in the debulking nature, is there a benefit to survival? So this is a study that has been going on for several years in Holland. We've tried to open in the UK unsuccessfully. They've got several hundred patients recruited. We will wait for an answer. So it may be that in the future there is a role for debulking surgery. At the moment there isn't. But the intention with the portal lymph node and the liver metastases is to resect all sites to hopefully improve chance of cure. But yes, they will do worse than someone who doesn't have extrahepatic disease.
Thank you, sir.
Any other questions? Any other hands?
One last question, yes, Dr. Gamal Amira.
Hello, Dr. Hassan. How are you? Thank you for this Nice presentation.
Thank you.
My question is, what are the proper indication for direct upfront resection for both? When we do upfront without neoadjuvant or without chemotherapy?
I don't know. I mean, I think there's your heart in your head, isn't it? So if you look at the data from Rennie Adam and LiverMet survey, which is at several thousand patients in that series, he says that, look, if you have a solitary metastases, then you can go and operate on that without upfront chemotherapy. But if you read the paper, they would always recommend adjuvant chemotherapy. If you look at the original study, which was the original EPOC study, it showed a benefit in terms of PFS of, preoperative chemo, surgery, postoperative chemo versus surgery alone. So, and those cases weren't synchronous, So I think in the presence of synchronous disease, the vast majority of patients, we would recommend upfront systemic chemotherapy. The caveat being the chemotherapy has toxicity, the tumor may disappear, whatever else, okay? But I think there is a small group of patients who may be unfit for chemotherapy and whom you may say, well, okay, it's a low volume metastatic disease, like one lesion and a right colonic tumor, for example. Yeah, fine, resect the colonic tumor and the primary, but that would be someone who may not be fit for systemic chemotherapy, in whom you may do that. But the majority of cases, the recommendation would be to give systemic chemotherapy. And remember, also, as someone with a small solitary metastasis who's unfit, you can easily ablate that. And then the only problem is dealing with the primary tumor, which the local team can arrange. So I think it's difficult. So yes, you can always find exceptions to the rule. So the thing I mentioned in the talk about biopsying, not biopsying, although that is true, but if you have got a patient with more than one malignancy in their past medical history, so we see patients with breast cancer and a colon cancer. So you need to biopsy the liver to know what the metastatic tumor is. So there will always be exceptions to the rules. Yeah. But in the majority of cases, we would recommend chemotherapy.
Thank you.
Any other questions? Okay, I think that was it regarding the questions. Thank you, Dr. Hassan. Always a pleasure to have you with us. I think you're our #1 speaker.
Thank you. I'm always happy to help and have these conversations. And as I said before, what would be good is to maybe do a tumor board and have you guys present some interesting cases and me have an open discussion about strategies and things.
Yeah, it would be nice, but the logistics would be difficult because right now I'm, for example, working in the breast department, so I'm not even in the GIT department anymore. So
colleagues who are there might be able to share cases as well.
Okay, yeah, I'll look into that.
Yeah.
Okay, so we'll get in touch. Let's see if we can do another webinar maybe in a few months.
Perfect. All the best. Assalamu alaikum.
Thank you and good night, everyone. Bye.